Our third speaker this morning is Joyce O'Shaughnessy from the Baylor Sammons Cancer Center, who's going to talk about DNA repair, PARP, or target in evolution.
Thanks, Dan, and thank you to Bruce and to the organizers for inviting me here this morning. It's great to be back, my old hometown of Boston, and where I did my residency here with Dan at NGH. It's good to be back. So as a clinician, I find myself standing in the clinic day in and day out looking at the phenotypes of these patients and then trying to match up the genotypes. And I'm very interested in triple-negative breast cancer, and we'll give you some musings that I have about some data from the clinic, actually, that's pretty provocative with regard to PARP inhibition, but also since PARP inhibitors are probably not going to work for all triple-negative breast cancers, what are some of the other DNA repair abnormalities that may be operable that we may want to eventually understand? The learning objectives. Okay, good. So there's some, well-described mechanisms of DNA repair, a base excision repair that repairs single-strand breaks, nucleotide excision repair that repairs bulky adducts, and then the double-strand breaks that are particularly lethal to cells, repaired by homologous recombination or non-homologous end joining, and then mismatch repair, the spell checker, when there's an abnormal base deleted or inserted. And so we tend to think of those as sort of categorical, but in fact, as I'll show you here in a second, there's a tremendous amount of overlap and redundancy in these pathways. But because the double-strand break is so lethal, there's been a lot, and because BRCA1, BRCA2 mutations lead to double-strand repair abnormalities, there's been a lot of focus on double-strand breaks and problems with this pathway that may lead to particular chemotherapy sensitivity to agents that cause double-strand breaks. So, of course, ATM and BRCA1 are extremely important in repairing these double-strand break lesions, but there's a whole bunch of other proteins that collaborate with them, and I'll show you here a list, but PALB and BRIP and the MRN complex, RAD51, there are a number of these that come up as we read about inherited predispositions to breast cancer. So this is a situation where probably abnormalities in any one of these, or at least in a constellation of them, will lead to some relative reduction in the efficiency of double-strand repair breaks. Now, we're all familiar with the BRCA1 germline mutations, and an interesting piece of work underneath the picture there from ASCO Breast just in September, Dr. Gonzalez Angulo from MD Anderson went back into some archival triple-negative breast cancers where the germline mutation status was not known, and found that about 20% of these triple negatives had BRCA1, 3/4 of them, or BRCA2, 1/4 of them mutation. So that's kind of interesting. So cells with BRCA mutations or abnormalities in this pathway do not efficiently repair double-strand breaks, and so therefore become reliant on other mechanisms of DNA repair to compensate for this loss of the ability to repair double-strand breaks. This is a partial list, it's certainly not complete, of inherited defects in homologous recombination. And as I've looked at the literature, with the exception of BRCA2, where the breast cancers tend to be ER positive, when I read the literature, it looks to me like most of these are triple negative, the kind of breast cancers that patients get who have these inherited defects in homologous recombination. Now, this is a recent paper that kind of shows that it's not just HR and non-homologous end joining that's involved in a double-strand repair break. The mismatch repair pathway, nucleotide excision repair pathway, and even PARP itself and the base excision repair pathway, they all can kind of step to the plate and take over and do double-strand repair. So it's a very redundant pathway with pathways coming up and down depending on relative deficiencies in some of the pathways. So PARP is a very, very interesting protein that is a very, very plentiful nuclear protein that is the central protein in base excision repair. And PARP1 repairs single-strand breaks and double-strand breaks, and it's involved in the backup non-homologous end joining. PARP2 is involved in base excision repair. PARP1 repairs stalled DNA replication forks. It's hyperactive in homologous recombination deficient cells with high PAR polymer levels. And PARP1 inhibition in P53 deficient breast cancers restores anthracycline sensitivity. So we see here the big PARP protein that binds to single-strand breaks, and then it consumes NAD to make these PAR polymers here that lead to a little bit of nanomolar unwinding of the DNA, and provided not enough NAD has been depleted to cause a necrotic cell death, the cell will survive, and then a PARP recruits in a number of other collaborative proteins that then repairs single-strand breaks. It's a very, very pleiotropic protein. There are about 17 to 20 members of the PARP family, but PARP1 is probably the most important. We certainly know the most about it, and we see at the top right that it parcelates, puts those PAR polymers on a wide variety of proteins involved in DNA repair, DNA methylation, transcription factors, and chromatin histone modification. So quite a large number. Some of the PARPs are tankrase 1 and 2, which parcelate telomeres and maintain chromosome stability. PARP1 promotes autography in response to DNA damage as well. So it's a very, very pleiotropic protein. I really liked this particular paper here that shows this PARP1 signalosome. In response to DNA damage, PARP1 parcelates proteins and leads to this scaffold that ATM and I-kappa kinase can bind to, and it leads to the simulation of NF-kappa B activation. And so one could imagine that inhibiting PARP1 with a PARP inhibitor could lead not only to problems repairing DNA, but could also lead to interruption of NF-kappa B activation. So with that little bit of background, just turning to some of the clinical data, the oral PARP inhibitor Olaparib was taken into BRCA1/2 mutated and pretreated metastatic breast cancer patients because of synthetic lethality shown by Ashworth and colleagues. And it looked very, very promising. Up at the top, underlined their response rate with the higher dose of 41% and median progression-free survival just with a single agent in pretreated metastatic breast cancer patients was extremely promising. Interestingly, these few patients here that did not have a response had been pretreated with platinum, so they were platinum pretreated resistant patients, interestingly. Now, a subsequent study was at ASCO this year looking at ovarian cancer patients and breast cancer patients. And down here, if we look by BRCA status, down here again, this is Olaparib, single agent Olaparib. And in BRCA mutated ovarian cancer patients, it still was quite promising. Unfortunately, in 8 breast cancer patients that were mutant BRCA, activity of Olaparib was not seen here. Even in non-BRCA mutated ovarian cancer patients, there were 24% response rates, which is encouraging. It's not clear yet what the pretreatment characteristics of these BRCA patients were that did not respond to Olaparib. You know, for example, how much platinum had they seen, for example. So we'll have to have more details about that. Now, this is an interesting study that probably illustrates that we need to know a little bit more about DNA repair pathways, as I'll get to in these patients that we're treating with PARP inhibitors. But putting temozolomide, the DNA methylating agent, together with another oral PARP inhibitor, Veliparib, showed activity in 8 BRCA1/2 mutant metastatic breast cancer patients, 37.5% response rate with a median progression-free survival of 5.5 months, which is quite encouraging, but really no activity here in 33 BRCA1/2 normal or unknown patients. So this particular PARP inhibitor with temozolomide was not active, and the efficacy was really restricted to BRCA1/2 mutation carriers, even in combination with the temozolomide. So we decided to look at triple-negative breast cancer patients because of a number of lines of evidence suggesting that at least a portion of triple-negative breast cancer patients have defects in homologous recombination, whether it be BRCA1, germline mutations, or methylation of BRCA1, or upregulation of ID4, for example, that leads to a decreased BRCA1 protein. So there's a number of mechanisms, and we did a proof of concept study in 120 triple-negative breast cancer patients that had been pretreated with 0 to 2 prior chemotherapy regimens. They had measurable disease, and we gave gemcitabine and carboplatin in a split dose, day 1, day 8, along with the IV PARP inhibitor, Iniparib, day 1, day 4, day 8, day 11. And patients who were randomized to Gem-Carbo alone at the time of progression had the opportunity to cross over and continue the Gem-Carbo and receive the Iniparib. So Iniparib is a small molecule with PARP inhibitory activity that competitively inhibits NAD binding to PARP. It potentiates the activity of DNA-damaging agents and irradiation and does penetrate the blood-brain barrier. And in phase 1 studies, no dose-limiting toxicities were seen by itself or in combination with chemotherapy. A very nice paper from Stanford showed that gemcitabine and cisplatin each have synergistic activity with a different PARP inhibitor, PJ34, in basal triple-negative breast cancer cell lines. This work also suggested that these basal triple-negative breast cancers not only had defects in homologous recombination, but also had defects in nucleotide excision repair. And PARP inhibition decreased P63 levels, releasing P73 pro-apoptotic activity in the face of inefficient repair of DNA damage from gemcitabine and cisplatin. So very nice preclinical synergy with PARP inhibition and gemcitabine and cisplatin separately. These are the final survival results from the phase 2 trial, just recently presented them at ESMO, showing a hazard ratio of 0.57 and improvement in median survival from 7.7 months up to 12.3 months. That was statistically significant. About half of the patients randomized to Gem-Carbo crossed over to get the Gem-Carbo Iniparib at progression. So these are the survival curves in spite of the crossover. We did take a look at the outcome of the patients who crossed over to have the Iniparib added. You see up at the top there, 30 patients. It was half of them. They only got a median number of cycles of 1.5, and 83% discontinued treatment after 1 or 2 cycles, and there was only 1 unconfirmed partial response. So not a lot of activity seen with continued Gem-Carbo with the Iniparib added in, suggesting, again, and consonant, I think, with the findings by TUT with the Olaparib, that coming in with the PARP inhibitor after cisplatin resistance doesn't look particularly fruitful. So the phase 3 trial has been completed, the exact same design, but 500 plus patients. It will be reported first quarter next year, and then there's an expanded access protocol going on now for metastatic triple-negative breast cancer patients to have access to the triplet. So the question then becomes, well, how do we identify breast cancers that may be dependent on PARP for their DNA repair? They have defects in homologous recombination, so they need PARP. So how can we identify them? And one piece of work that I really liked from Jenny Chang and Rodriguez at Baylor Houston was at San Antonio last year, looking at a Loravantavir 25-gene signature that looks at BRCA1-like breast cancers. And they went into the public databases from Baylor, Wang, and NK12 data sets and looked at 174 triple-negative breast cancers in that data set and applied the 25-gene assay and found about a 50-50. About half of the patients had BRCA1-like gene signature and half did not. And you can see down the bottom upregulation of PARP1, RAD51, CHEK1, and Fanconi anemia genes in these patients that had BRCA1-like breast cancers, and half did not. They further looked at top driving pathways in these cancers, and on the left, the BRCA1-like check proteins and checkpoint control, polo-like kinase, BRCA1 DNA damage response genes, and ATM signaling, all things we would expect in the setting of BRCA1-like pathway abnormalities. And then interestingly, on the right, non-BRCA1 triple-negative breast cancers had hepatic fibrosis, stellate cell activation, activation of the coagulation system, IGF-1, and PDGF. And as a clinician, this resonates with me. Certainly, we have patients that do not benefit at all from the DNA-damaging agents that are so effective in patients with BRCA mutation, triple-negative breast cancers. And the ones on the right tend to be really resistant to platinum. And the question is, what are their DNA repair pathway abnormalities? It does not appear that they have homologous recombination defects. What are their defects, and can we exploit that by making better choices of cytotoxic therapies? Down underneath the table there, you see a couple of recent references that show that other in vitro predictors of homologous recombination defects and sensitivity to PARP inhibition are PTEN loss, leading to RAD51 dysfunction, and Aurora A upregulation, which represses homologous recombination. And both of these are common in breast cancers. A recent publication is quite interesting from August of this year, looking at low RAD51 homologous recombination capacity, predicting for pathologic complete response with preoperative chemotherapy. These patients were treated with anthracyclines in combination with an alkylator or a platin, and they were biopsied 24 hours after their first dose to assess homologous recombination with RAD51 foci by immunofluorescent microscopy, 68 patients. And low RAD51 scores were seen with high grade, high Ki67, and in 67% of the triple negatives, and in 19% of HER2 positives or ER positives. The pathologic complete response rate was 33% in patients with a low RAD51 score and just 3% in the others. So the low RAD51 present in triple negatives and some other cancers predicts for anthracycline, and again, it wasn't just single agent sensitivity. So that's quite interesting and maybe a useful marker of these cancers with homologous recombination defects. So what about other defective DNA repair pathways in breast cancer? We don't know a lot about this, and I think it is something that is ripe for better understanding, for more rational design of therapeutics. So we've mentioned the BRCA1 pathway here, so central to DNA double-strand repair, homologous recombination. ATM and ATR are also integral to this, this complex here, and so we do know some things about ATM in breast cancer. ATM, ataxia-telangiectasia mutant kinase, controls G1S checkpoint, activating cell cycle arrest and DNA repair. It's a member of the PI3 kinase-related family. And homologous defects in ATM lead to a high incidence of leukemia, lymphoma, breast cancer, and complex neurologic disease. ATM heterozygotes, it's an autosomal recessive with a 3-fold elevated breast cancer risk, but if you're under 50, it's a 5 to 9-fold elevated risk, and bilaterality can be seen. The ATM heterozygote is about 0.5 to 1% of the population and probably is felt to explain 3 to 6% of breast cancers in patients with a family history. So ATM heterozygotes breast cancers have increased sensitivity to radiation and increased late fibrosis. In an interesting paper that looked at about 1,000 BRCA1, BRCA2 wild-type breast cancers and looked at ATM kinase protein expression, 20% of the triple-negative breast cancers were ATM deficient, and we would surmise that they would also have problems with homologous recombination. And 10% of the ER positives or HER2 positives were ATM deficient. Interestingly, 1/3 of BRCA1/2 mutant cancers were ATM deficient. ATM deficiency leads to hypersensitivity to CPT11 camptothecins via DNA-dependent protein kinase cell death. And what's interesting is this paper actually looked at, from adjuvant breast cancer patients, looking at ATM wild type versus ATM low in the setting of a P53 status. And over on the right, you see that in the setting of a P53 mutation, that having ATM low is a synthetic lethal to the cancers. The patients do very well. No one's recurring, because if you knock out both P53 and ATM, you get mitotic catastrophe, so the DNA-dependent protein kinase pathway. Conversely, if P53 is wild type, then you have enough time for cell cycle checkpoint and DNA repair down that DNA-dependent protein kinase pathway. And so if your ATM is wild type in the setting of P53 wild type, people do well, but ATM low in the setting of P53 wild type, patients do poorly. So I think that these are going to end up being quite relevant to us as we understand the natural history and the prognosis of patients. Now, ATM defective mantle cell lymphomas are sensitive to the PARP inhibitor Olaparib. So again, in the setting of loss of homologous recombination because of ATM deficiency, more reliance on base excision repair and PARP, and Olaparib kills these mantle cell lymphoma independent of P53 status. And we see here no drug, and then if we add the Olaparib here to the alkylators or to valproic acid, we see a nice synergy here, suggesting that ATM deficiency really does lead to a homologous recombination defect. So the other type of DNA repair deficiency that I think we need to investigate more in breast cancer is mismatch repair deficiency, the microsatellite instability mutator phenotype. And so some information is known about MMR deficient breast cancers. They're high grade, high Ki67, more tendency to be lymph node negative, confluent necrosis, peritumor lymphocytes, less LVI, and about 60% of them are triple negative. They're all HER2 negative. In colorectal cancer, MMR deficiency is felt to lead to resistance to a wide variety of agents, the ones most important in colorectal cancer, 5-FU and platin, but to more sensitivity to oxaliplatin, camptothecins, and etoposide. And these are agents that we don't tend to use much in breast cancer, but we would need to really focus on these if, in fact, some of our breast cancers are MMR deficient. MSH2 mutations are synthetically lethal with methotrexate. And interestingly, because MMR deficiency leads to a mutator phenotype, there's a lot of other mutations present. Ones in pink there, P10, RAD50, and ATR, lead themselves to deficiency in homologous recombination. 15% of colorectal cancers are MMR deficient and are sensitive to PI3 kinase pathway inhibitors. So there's a number of implications of knowing MMR status. MMR, when it's intact, it suppresses homologous recombination. And so intact MMR cells are sensitive to platin and bleomycin. MMR deficient cells increase homologous recombination and therefore are efficient at repairing double-strand breaks induced by platin and bleomycin. MMR deficient cells, conversely, increase base excision repair, and you can restore temozolomide sensitivity in MMR deficient cells with PARP inhibition, provided P53 is wild type. So that's quite interesting to think that PARP inhibitors might be useful in MMR deficient cells, and that's why I was interested in the Veliparib temozolomide phase 2 study that didn't see any activity in 33 breast cancers, metastatic breast cancers, but the MMR status of those cancers was not looked at. So this could have very clear implications for design of clinical trials. This is an interesting paper back from 10 years ago now, looking at loss of the MMR protein MLH1 after neoadjuvant chemotherapy in locally advanced breast cancer patients. Down the bottom, you see they received FAC or an anthracycline, cisplatin, and you see that some of the patients have stable amounts of the MLH1 after treatment, but some have a significant loss of MLH1 after treatment with preoperative chemotherapy. And the prognosis, these are small numbers of patients, it was not a prognostic factor, the MLH, whether the MLH staining was high, over 80%, and they look at intensity score. So actual staining or intensity score of staining, it didn't make any difference. It was not a prognostic factor preoperatively, but after chemotherapy, looking at the MLH staining in the residual breast cancer afterwards, patients who had loss of mismatch repair in the residual cancer did much more poorly than patients who did not, suggesting that this is a poor prognostic factor in breast cancer. So in summary, as I look at across these data sets, the early data suggest that perhaps up to 20% of triple negative breast cancers may harbor BRCA1/2 mutations. About 50% of triple-negative breast cancers may have BRCA1-like expression profiles. About 20% of triple negatives may be reduced for ATM protein expression and have HR deficits. Mismatch repair deficient breast cancers tend to be triple negative, and in one paper, 16% of breast cancers from families with breast and colon cancer were MMR deficient. So it may be a similar percentage as we see in colorectal cancer. And these DNA repair defects may predict for sensitivity to inhibitors of compensatory DNA repair pathways, to chemotherapy, to PI3 kinase inhibitors, and others. And so there's a vast number of inhibitors in development now, to inhibit PARP, of course, but also CHEK1, ATM, DNA-dependent protein kinase, RAD51, so a wide variety of these. And we really are going to have a good handle on the intrinsic DNA repair defect in these breast cancers in order to know how to deploy these and with what chemotherapy. So in conclusion, the PARP inhibitors appear promising as inhibitors of homologous recombination deficient BRCA1, 2, and possibly triple-negative breast cancer. The phase 3 of Iniparib in metastatic triple-negative breast cancer will be available first quarter next year. We have the paraffin blocks from the phase 2 and phase 3 studies and have done transcriptional profiling, and we're looking at a wide variety of expression signatures to look at all of these DNA repair pathways within the tissue to see if we can match up benefit from the PARP inhibitor with homologous recombination defects versus mismatch repair defects, for example. Identifying mismatch repair deficient breast cancers may be of interest because there may be a role for irinotecan, methotrexate, oxaliplatin, PARP inhibitors with temozolomide, some agents that are felt to still work in MMR deficient states. And ATM deficient breast cancers are homologous recombination deficient and may benefit from PARP inhibitors and from double-strand break-inducing cytotoxic agents. So thank you. Thanks for your attention.
So for those unhappy individuals who've been trying to find biomarkers for PIK3CA, they now have a bigger challenge, which is to find biomarkers for DNA repair. Is it fair to say that if a tumor has a mutation in BRCA1 or 2, it's likely to respond to a single-agent PARP inhibitor? But if the pathway is mitigated in some way by expression profile, protein loss, or other less genetically defined markers, you're less likely to get a single drug response, but more a combination that would be appropriate. So do the drugs help give you clarity in terms of the biomarkers?
I think that's right, and I think that the loss of BRCA1, BRCA2 is such a huge loss that the reliance on PARP may be so extreme that you can see the synthetic lethal, provided that it's not now resistant to the PARP inhibitor because it's already gotten around platinum, for example. But I think that's right. I think we have to stress the system to really put maximum pressure on it in situations where there's a lesser degree of homologous recombination defect. So I think you do have to stress the cell and then inhibit the pathway that it needs to repair the DNA.
Zoltan?
Do you see any potential risk of using? Do you see any potential risk of using PARP inhibitors in the neoadjuvant setting in terms of higher incidence of secondary cancers? I mean, you're inhibiting, DNA repair pathways, and with, anthracyclines, you have like a 0.5% secondary tumor incidence. And I was just wondering, what's the, sign? Is there any, back of the envelope calculation what you would expect? Because there are ongoing neoadjuvant PARP inhibitor trials. So.
Right. No, and I think the hope is that just because of the pulsatile nature of the delivery of the PARP inhibitor, just with the chemotherapy, that if you pick up some additional secondary malignancies, that it will be small. But no, I haven't seen any calculations. It's clearly a risk. And I think it's the other thing people think about, of course, is in the preventive setting in patients who harbor BRCA1, BRCA2 germline mutations. What do we do? And I think the hope there would be that when individuals reach a certain age where they may have pre-malignant lesions, for example, that may be a pulsatile, a 6 months, to kind of clean those up a little bit, and then come back in a future point, So rather than continuous inhibition, I think is probably going to end up being more problematic.
But there are no ongoing animal models or something?
Not that I've seen.
Other questions? Oh. Sorry, Bill.
model. So eventually that kind of data would have to be generated for a PARP inhibitor where you expose rats for 2 weeks. So someone will have that data at some point. The question I had was on this story of reversion of the BRCA1 back to a truncated yet wild-type functional form of BRCA1, which then, of course, eliminates the synthetic lethality. And this was just an amazing story from a couple years ago. I wondered what the update was in terms of either randomized trials or people progressing on PARP inhibitors to what extent is reversion of the BRCA1 allele now documented or further documented?
I have not seen any additional data come out from the clinical trials to see how often that occurs. There's a recent paper that's interesting, though, that caught my eye with regard to these are in vitro studies now. They may have been animal studies showing that in BRCA2, this was in BRCA2, germline mutation cancers that become resistant to platinum and resistant to PARP inhibitors, that it appears to be upregulation of mismatch repair. So it's intact mismatch repair taking over, and 6-thioguanine will kill the cells. So again, sort of a an compensatory upregulation that 6-TG will kill. So it may not just be just the conversion story. It may be upregulation of some of these other pathways.
Bruce?
Simple question. Are all PARP inhibitors the same?
No, it gets back to that potency thing we were talking about earlier, and I think they certainly won't be the same. The Iniparib one has, it's at its parent compound, its potency is at the micromolar range. It's got a nitroso metabolite that is intracellular and a little harder to measure and know its exact potency. So no, they're not. And the thing about them is that these PARP1 does so many things, and it's involved in metabolic pathways too, with NAD depletion, et cetera. So they're pleiotropic, but no, they're definitely not going to all be the same, and certainly their host toxicities are vastly different.
Bob?
I think your observations in neoadjuvant are very interesting. Those patients are resistant and respond on the PARP. Do you expect them to respond thereafter again on the chemotherapy?
I think we really need to know. I mean, what are the mechanisms of the resistance to the PARP inhibitors? I am very interested in this whole DNA repair pathway story because there's definitely compensatory upregulation, and we know enough about our cytotoxic agents to know. And so I think we really need to be focusing more on mismatch repair from a clinical standpoint, and this is strictly anecdotal. Drugs like the camptothecins, can come in and help these patients, after they've progressed through platinum and after they've progressed through PARP inhibitors. So they may have MMR intact.
But they may also become sensitive again to the previous drug.
Yes, yeah, I think if enough time goes by, certainly the case. And certainly I've switched, and again, these are strictly anecdotal, but when you go to other DNA damaging agents like mitomycin C and to etoposide, for example, you can still get some benefit to patients. So even with progression on PARP inhibitors, but and these patients are, they get out far enough that you can come in with other double-strand inducing agents.
Thanks very much, Joyce.